Today we are going to discuss elbow dislocation. First, we'll see the anatomy of the elbow joint. Elbow joint is a modified hinge joint. It has three separate articulations comprising ulnar trochlear, radiocapitular, proximal radioulnar. The elbow joint has the several stabilizers. These are the static and the dynamic stabilizers. The soft static stabilizers comprises the joint capsule, lateral collateral ligament, medial collateral ligament. Dynamic stabilizers comprise biceps brachialis and triceps. Movements of the elbow joint comprise the flexion, extension, supination and pronation. This is a picture representing the several movements of the elbow joint with the involved angulations and degrees. The capsule of the elbow joint has the anterior and posterior covering. The joint capsule is thickened medially and laterally, which forming the collateral ligament, which stabilizes the flexion and extension of the joint. The lateral ligament complex comprising the radial collateral ligament has attachment to the lateral epicondyle of the humerus. The distal fibers blend with the fibers of the supinator, the annular ligament that encloses the head of radius along with the supinator and the extensor carpi radialis brevis. It helps in prevention of the adduction of the elbow joint. The annular ligament of the radius reinforces the joint by holding the radius and ulna together in the proximal articulation. The quadrate ligament present at the joint and maintain constant tension during the pronation and supination movements of the forearm. The lateral collateral ligament at the lateral epicondyle of the humerus inserts at the supinator crest of the ulna and plays vital role in posterior stability of the joint. Ulnar collateral ligament is the medial collateral ligament extends from the medial epicondyle to the coronoid process of the ulna. The dislocation of the ulnohumeral joint, that's elbow joint, is commonly occurring during the fall on the outside hand or elbow. It's classified into posterior, anterior, lateral, medial and divergent. The posterior dislocation is a combination of elbow hyperextension, valgus stress, arm abduction, forearm supination. In less than 10% posteromedial can occur. In other dislocation, posterolateral is common. The most elbow dislocation and fracture dislocation result in injury of the all capsulo-ligamentous stabilizers of the elbow joint. This is the various stages involving elbow joint dislocation. The elbow instability can be taken into posterolateral rotatory instability, valgus instability and varus posterolateral rotatory instability. The associated injuries along with the elbow joint dislocation comprise minor and major varieties of trauma. The simple elbow dislocations are not associated with the fractures. Disruption of the collateral ligament, elbow capsule and forearm flexor and extensor muscle origins. Injury to the brachial artery has been described in the simple location, but nerve palsies are also possible. Ulnar nerve is the mostly commonly injured nerve following the elbow dislocation. Fracture dislocation can occur in cases of the elbow dislocation, whereas the radial head fracture comprises up to 5 to 11%, the medial lateral epicondyle fracture comprises 12 to 34%, associated coronoid fractures up to 10%, the singular comminuted fragment involving 50% coronoid or less. Type 3 is the singular comminuted fragment more than 50%. Fall on outside arm, the extended arm can be the mechanism of the injuries. The signs and symptoms of the elbow dislocation comprise pain, swelling and obvious deformity will be present. Normally 3 bony point relationship is lost. Elbow flexor to 90 degrees, the medial, lateral epicondyles and olecranon passes should form the isosceles triangle. A complete peripheral neurological examination should be performed. The radial and ulnar pulses should be compared on both sides. The imaging the diagnostic studies which can help in the direction of the elbow joint comprise the X-ray and CT whenever necessary. MRI is not needed unless we suspect the any soft tissue injuries and vascular and neuro complications. The picture representing the joint efficient noted on the relationship of the radiocapital line. This is the posterior elbow dislocation, the anterior elbow dislocation. It's a terrible triad injury of elbow. The treatment algorithm: when it is simple elbow dislocation, we try closed reduction. If it is stable, we'll put the plaster Paris application. When it is unstable, we go for the surgical intervention whenever necessary. When after it's stable, apply plaster of Paris application. When it is still unstable, we go for the ligament repair also. This is the closed reduction technique, where the patient lie prone on a stretcher and the physician applies gentle downward traction of the wrist and the olecranon begin to slip displace. The physician lift up the arm gently. This is a main and quickly method. Only the forearm hangs on the side of the stretcher. A gentle downward traction is applied on the wrist and physician guides and reduction of the olecranon on the opposite hand. Approach, Kaplan's approach, several surgical techniques employed in the repair of the elbow joint. Post-operatively, the patient is placed in a well-padded splint with the elbow at the 90-degree inflection and forearm in pronation. The elbow should not be immobilized for a very prolonged time. Active motion is preferred over passive motion. If the MCL is intact and LCL is injured, forearm should be in pronation with supination to be done only with the 90 degree of the elbow flexion. If the MCL is injured and the LCL is intact, the flexion and extension should be performed and forearm maintained in supination. If both MCL and LCL injured, active range of motion should be performed with forearm in neutral position. Passive stretching should be performed after 6 weeks. The complications involving the elbow dislocation comprise the vascular injury that can happen to the brachial artery, nerve injury can happen to ulnar nerve, and the recurrent dislocation. The late complications include stiffness, heterotropic ossification, unreduced dislocation, recurrent dislocation, osteoarthritis after severe fracture dislocation. Thank you.